All right, everybody. Good morning. It's Bernard Nomberg, and it's Tuesday at 10 o'clock Central. So that must mean another weekly episode of Nomberg Law Live. And as we have been for over 3 years now, is we've been bringing interesting conversations with people in their areas of expertise. And I'm so pleased to have my former college teammate and friend Joel Walker from the Dallas Fort Worth area as my guest today. Joel, thank you for making some time for us.
Well, thank you for inviting me. It's been a long time since I've done a podcast.
Well, and it's been a long time since you and I've been able to catch up and to see each other live or virtually live. So thank you for making some time. I know you're in the middle of your clinic today, so we won't keep you longer than we really need to. But for those of you who don't know Joel, he's a primary care physician in the Dallas-Fort Worth area. And when Joel and I played football together at Vanderbilt, and then just life happened, we went our separate ways. But we're here today, and we're going to talk about the future of medicine with the pandemic that has just completely upset and turned over our entire world for just about everything that we do in the world. The medicine, how people receive their medical care through clinics, hospitals, etc., also vastly has changed. And Joel has a very active clinic, and we're going to get into that, what they're doing and what he sees is in the future for medicine. But before we do that, Joel, tell folks a little bit more about yourself and your clinic and the type of patients you see.
Well, I have a dual role. I'm actually a medical director half-time and a primary care physician the other half. So 3 days a week I'm in clinic like today seeing patients, and I'm also board certified in 2 specialties. I do pediatrics and internal medicine. So I really see patients from birth to my oldest patient's 99 right now. And I kind of skew towards the extremes of seeing the oldest patients and the youngest patients, but that's what I do in practice. My managerial roles, I'm administrator for clinics across 4 different counties here in Texas, kind of the southern edge of Dallas-Fort Worth. So I go from, people won't know the small towns, but I go all the way around south of Fort Worth. And so a couple of days of the week I'm on the road going to clinics and helping with the clinical management, the doctors, and I've been working at this role since the start of the pandemic, pretty much helping to coordinate our response to how to see patients, how to treat patients, and how to do so safely for our clinicians and for our patients.
Well, we're now 10, 11 months into the world changing from early 2020, and I know that in my practice, I don't have to see my clients face to face because I'm not examining them like a doctor does or making diagnosis. I can do it on the phone or FaceTime, whatever. But for the practice that you have and the doctors in your clinics, you necessarily do need to see them sometimes, I would assume. I know that telemedicine has been very popular, but what has been your patients' responses in dealing with these changes? Have they rolled with the punches, so to speak, or has it been a lot of hand-holding, literally and virtually?
Well, you know how people are, and people don't respond to change well. And this has been the biggest change in healthcare I've seen in my 25 years. EMRs were one thing, and electronic medical records, I should clarify. That was one change, going from paper charts to that, but this has been much, much more disruptive. And telemedicine can be hard, especially for my senior patients who may or may not be technologically adept enough to manage it. We have a lot of rural communities without internet access, so we've had to manage, and we have physicians who had to learn how to do it. We had no telemedicine in February of 2020, and by March we had rolled out a platform to all the physicians in the company, and we were all up and running and seeing patients virtually. Personally, I was not prior to this pandemic, much of an advocate for virtual medicine. I didn't see how it would be possible or useful, but since kind of my hand's been forced, I've learned to adapt it, and I've gotten comfortable with it. And just like we're doing this chat over Zoom, I can really do a lot of my patient care virtually. Mm-hmm. I have patients that I don't have to examine, patients with medicine refills for ADD for kids, adults that just need blood pressure checks and have their own blood pressure monitor at home, diabetes checks where they can just get their labs drawn. We can go over their labs. So there's a proportion of visits that we can do virtually. And then there's the others where I have to examine the patient. Mm-hmm. And we've had to be real creative with that too, because we cannot bring people into high-risk environments. So we've adapted curbside visits, kind of like going to Sonic. They pull up and give us a call, like I guess like people are getting their groceries nowadays, and we come to them and we bring everything out of the building and go, pardon me. Well, that wasn't too professional. But we'll go out to their car and see them in the car. I've had patients. We actually set up some large tents where we could put tables out and see patients outside. When the weather's nice, it's kind of like a Sunday picnic at some of these clinics with everyone kind of gathered around, you know, visiting. And so there's been a lot of things like that we've done. We will have patients come up that cannot use technology, and we have tablets that are pre-programmed where we'll have them drive here. My staff will bring them a tablet downstairs to their car, and I'll sit in my office and we'll connect virtually, but just from a distance. And that's been necessary to keep. We cannot let patients with suspected COVID-19 come into the clinic for fear of exposing every other patient and clinician here. Yeah, we still have a duty to treat them, so we've tried to find creative ways to do so.
Well, those all sound like very creative ways, and I'm sure a year ago, if you would have been asked, well, do you see X, Y, and Z occurring with your practice? I'm sure nobody would ever have predicted those kind of things, but now that you've learned so much and adapted and adopted so many new techniques, do you see some of the things that y'all are doing to provide patient care staying even after the pandemic really has subsided and people are safe and the herd immunity or whatever it is that takes place in the next 6 months, where maybe society comes back to some sense of what we knew to be the old normal? I hate using the term the new normal, but my question is, are some of these things that you guys have developed and using, will you continue, do you foresee continuing to use them in your patient care?
Well, absolutely. I think telemedicine is not going away, and for good reason. I mean, I get parents, I mentioned ADD. Just yesterday, I had a parent picking her kid up from school in the car, doing her visit with me in the school parking lot with her kid after school, going over their meds. Previously, she probably would have had to take her kid out of school early, come to the office, wait, come back, and we could do the same visit, and it would take up, you know, significantly more time for her, and it was no inconvenience for me to flip on the screen. Blood pressure checks are the same. I get people that, you know, I'm trying to control their blood pressure, hard to treat older patients, and they're coming in week after week just to check and see where they're at. Now they go home with a monitor and we talk, but they don't have to leave their house. So I see a lot of that going away, even once we have less need to socially isolate.
I was going to say, but Joel, some of these things are sounding like they're more efficient on some end, and it may allow you to maybe treat an additional set of patients each day, where maybe in the past, where they're sitting in your clinic or have the traditional settings, that takes a lot longer time. Yeah,
I can't say on my end that it's a whole lot faster because it involves, connecting and going through the visit and documenting it, and it's not much easier than walking down the hall to an exam room and do it. But for the patient, it certainly is. And we try and focus on the patient. So that's the biggest issue. Staffing-wise, it also is less burdensome on my staff, and they're able to catch up on other tasks while I'm doing virtual visits. So, but for me itself, it's about the same.
I was going to ask you about the staff in just a second, but guys, I'm talking with Dr. Joel Walker in the Fort Worth, Dallas area. He's a primary care physician as well as a medical director, and we're talking about how their clinics have adapted and changed throughout the pandemic and the things that they're doing now to provide patient care in the very best way that they can, including becoming mobile and getting out into the community. Joel, as a result of all of these changes, has some of your needs for certain types of staffing, nurses or whatever it may be, has some of that changed? Meaning, are non-MDs getting out and being able to perform certain functions that they're allowed to under the Texas Medical Association or the American Medical Association guidelines?
Yeah, a lot of some of the creative things we've done is involving not providers, physicians, or well, we use some APCs for this, advanced practice clinicians. Otherwise, people think of them as nurse practitioners or PAs. But we're doing a lot of kind of old-fashioned home visits where we'll send a team out to a home. They may bring one of the tablets we mentioned earlier that I can immediately connect to the home, so I can visit with the patient as well. And I'll have my staff out there doing their vital signs and checking them out. We're working with another organization, another part of our organization that does a mobile ER visit where they have a kind of a ambulance type rig with a EMS or a EMT and a physician assistant or nurse practitioner that goes to the home to assess things that are urgent but may not warrant going to the emergency room, breaks and need for IVs and heart failure and things like that, where they can go to the patient who's not mobile enough to come in. But we don't necessarily want to overload the ERs by sending them into there for something we can manage at their house. And so we're getting creative, like I said, in every way we can, and we're utilizing everyone we can. It's all hands on deck for this thing.
Is it still, have you guys, I guess, found a groove at this point, or is it still an evolving day by day or week by week scenario in the clinic or dealing with patient care?
We have developed pretty good systems and protocols and a pretty steady groove. Of course, this thing is constantly evolving. Right. We get new wrinkles pulled in. We get vaccine delivery that we have to try and worry about now and build that in. And the whole time, the motto we've had is that we're building this plane while we fly it. But we've got pretty solid systems. The only thing is we're facing what everyone else is facing, just kind of COVID fatigue, and trying to keep everyone on board and everyone aware of the protocols and personal protection and everything like that is a constant reminder we have to work on.
Does your clinic or the doctors you're affiliated with, do you all administer the vaccine, or how is that done in Texas?
Much like every state, there's a limited supply, and it's mainly run by the state. Currently, the county health department is the only one administering the vaccine. We are organized and set up to run vaccine clinics where we feel like we can get hundreds of patients done a day. But until we can get a supply of the vaccine, we can't do it. The vaccine storage for the 2 that have been released is a hurdle, and so we're going to have central facilities that have the type of deep freeze containers we can keep the vaccine in. So I don't see a day when we're going to be giving large amounts of vaccine in my clinic, but we will be getting them to our patients as soon as we can get vaccine for Moderna.
You know, it's interesting in Alabama. much like Texas, all counties have different sizes of population. In some of the smaller counties, you can call a hotline, and if you make it within the number of doses they have for that day, you get on the list. But in some of the bigger counties, you have to file an online application, if you will, and they'll get to you when they get to you, or when you fall in that certain category. So it's interesting to me that I guess each county health department, in some counties don't even have health departments in Alabama. Maybe it's that way in Texas as well. I don't know, but we have such small counties in certain parts of our state that you could go into another county and call that hotline. They don't care who you are. If you get on the list for that day, you can be administered the vaccine. So it's interesting. County by county in each state is a little bit different how they're doing it. But I'm just glad that they're doing it. Joel, let me ask you this. Let's move forward into 2022, 23, et cetera. And you've already mentioned some of the things that you think that may be applicable or may still be with you for giving medical care. But I guess my question is, are there other things that are being considered in delivering medical care that haven't either been approved yet or that you guys haven't jumped to that you'd like to see as future for medical care? I know that's a very open question. I guess it's a wish list, something that may aggravate you that, gosh, I wish we could do it this way, but not yet.
Well, I'd say the wearing of masks in public during high disease prevalence is a game changer. If we could get more people doing that, if it becomes popular, we could see the decrease in flu season, this constant belief that we have to get sick every winter time because of spread of viruses. To reflect on it, I haven't seen one of my patients with flu this year. Normally I'm up to my eyeballs in a flu epidemic by now. There is some limit to my patients with respiratory clinics coming to see me directly, but even then I haven't heard of any of them having the flu. And I don't know of any of my friends, family, or contacts who've had the flu. So it seems like wearing the mask for COVID has helped protect us from flu for a year or so. And so that may be a positive side effect. And if we become more socially accepting of wearing a mask when you're sick, going to the grocery store wearing a mask where you're not coughing everywhere, more people washing their hands and using hand sanitizer, I think we could decrease public spread of infectious disease greatly. Of course, that's become a hot topic, and I'm not sure that it's ever going to be accepted to the point where I wish it was.
You know, it's not to turn this into a political medical show, but it just seemed like it was politicized so early on, and maybe there's a change coming for the better, that more people hopefully will wear them. I will say this, I have noticed in the bigger cities in Alabama, the higher percentage of people who do wear masks in public and don't grouse about it nearly as much as the smaller towns. And I don't understand the mentality other than of the smaller town populations, but I know in the larger cities such as Birmingham, Montgomery, some of our bigger cities, like we have UAB Hospital, and that's the COVID hospital here for our state. And maybe it's just more a daily reminder in the bigger cities. I don't know if you see that in Texas, but it just seems the smaller the town, the less likely people are wanting to comply.
I'm, of course, in a major metroplex, but I go from small suburbs to large suburbs, and I see it pretty prevalent, the vaccine denial. There's some areas that do seem more politically averse to it. They tended to vote in a certain way during the election. But Yeah, I do get your point. My family took a road trip for our only getaway this year to Pensacola, of all places. And so we drove through Alabama, and I could say that we noticed much more mask wearing in Alabama than once we crossed the line into Florida. And I don't know if that speaks to the two states or not, but that was our personal observation. Anyway, yeah, I would love to see more acceptance of people wearing a mask in public and less feeling that you don't need to, more regard for your fellow man. It's going to be easier with other diseases. COVID being spread by people that don't show symptoms yet is different from the flu. You know, when you have the flu, you feel sick within a few hours of being contagious. And so those people wearing a mask, I'd love to see the school districts that no longer keep perfect attendance rolls and put pressure on kids to come to school sick and spread these diseases. I'd like to see them kind of roll that back and go to more public health. So hopefully we're going to get into a mindset of you know, putting your neighbor in front of yourself and more of a public health mindset in America moving forward from this thing.
I've said this many, many times as when I close my show here, when I remember to say it, you may not want to wear the mask for yourself, but consider the general public, wear it for other people. Absolutely. Joe, we got just another couple of minutes, and I appreciate your time today. I do want to ask you, I've read or heard that there are different strains or newer strains of the COVID-19 that are out. And I guess I've been asked a couple of times, do the current vaccines that are being administered, are those going to cover the newer strains or the different strains that are coming out?
It's believed that we will get at least limited coverage from the current vaccine over some of the newer, more mutated strains. Most concerning one I've seen is the South Africa strain, which has a lot more mutations in the little points that come off of it that the vaccine is directed at. Moderna is already acting on that and resequencing these new virus mutations, and preparing to produce boosters particularly for that. So if it becomes the most prevalent strain, you may have to go in and get another booster, which is kind of frustrating to hear when we're having so much trouble delivering the first round. But once we get this systematically rolling out faster, it should be a quick turnaround to get the booster. That's the exciting thing about this, is the RNA vaccine process, which some people are leery of because it seems to be something that came out of the blue and just rushed out for this. But it's been a scientific process that's been in the works for many years. It's just the first vaccine we've been able to use it on. And the speed with which you can create a vaccine based upon a genetic profile of a known virus will be remarkable in the future. I'm hoping that this can be applicable to other things where we could get a vaccine to prevent us from getting regular colds, regular coronavirus, or maybe a universal flu vaccine where we don't have to get a booster every year. Well, so that would be exciting.
Two last questions before I get you out of here and get you back to your patients. The first one is, after the person has the vaccine and then gets the second shot, assuming it's that company's medicine, do you, and I think I know the answer to this, but do you still advise that people continue to wear masks for the next several months?
I kind of like the current 100-day theory. We'll reassess further on as we go on. But, you know, right now we do not know that the vaccine prevents you from being infectious. Right. We know it prevents you from having a severe case that'll wind up in the hospital or wind up, you know, severely ill. It's about 96% effective in preventing any kind of severe case of COVID. But we don't know for sure that you don't get COVID enough that you might spread the virus. And since we don't know, it's best practices right now to still act as if you could spread the virus look out for your fellow man. Wear a mask to the grocery store. Don't get in huge crowds yet, and wait until we know more.
Thank you. Last question along these same lines. Do you foresee that, just like many who are advised to get the flu shot each year, will the coronavirus shot or vaccine be potentially a yearly recommendation?
It depends. Since we're just doing the first round of this, we don't know whether this will cover the mutations in the coronavirus.
Mm-hmm.
This coronavirus seems to be mutating about as rapidly as the flu does, but the fact is, with the flu shot, we're targeting the part of the flu that mutates, and so that's why it's so rapid that the flu vaccine no longer works.
Mm-hmm.
With this one, we're hoping that we get enough stability in the coronavirus that the vaccine will continue to work for many years. But it's possible you may need to get a booster with your flu shot every year until we can work around that.
Gosh, there's hundreds of other questions, but I'm going to pause for now. Joel, thank you so much for spending your time sharing your experience and your expertise with our audience about the future of medicine, about what's currently going on with the vaccine and all of those related things. So thank you very much.
You're welcome. And yeah, I can make time for you anytime if you want to revisit this.
Well, we may do that the next 6 months or so. Thank you. Guys, as always, 30 minutes comes and goes so very quickly in these conversations, because when you're having interesting conversations with people in their areas of expertise, it just flies by. So I want to thank everybody who stopped by. We had a few comments and some folks come by. But as always, Tuesdays at 10 o'clock, Nomberg Law Live. Hope you guys have a fun but safe week, and we will catch you another time. Take care.